Are you leaving a large dead space? Are you closing the thing very nice and tight so that every single bite produces areas of micro ischemia? How are you actually closing the wound? Following the principles of surgical healing or not makes a huge difference. And another important thing that surgeons, particularly surgeons who are there on wounds for a very long time, appreciate when we deal with wounds and we come back after 1 or 2 hours and you look at it, particularly the muscular, you don't notice it in the abdomen because abdomen is constantly secreting peritoneal fluid. You notice it in the limbs that you operate. If you take a large flap, you come back to it after 2 hours under the air conditioning of the theater and the theater lights, it's dry. And today we know 100% for sure that unlike earlier days when they used to say dry a wound out, we do not like drying. The whole concept of occlusion and wound healing has appreciated the fact a wound healing is almost like our being born again. In a womb, the first blastocytes and the first few cells start forming, they start forming in a wet, immersive atmosphere. The first life started in the ocean, not in the land, in the ocean, in a wet atmosphere. A wound healing is almost like that. Life starting, almost like a womb forming. So we cannot afford to have any wound desiccating. So these are the important things. We must keep this every day in mind, every second in mind when we operate. Okay. I talked about wound infection. A word about wound infection. We no more talk of wound infection in a broad term. We used to talk about that, but sometime about quarter century ago, CDC renamed wound infections as surgical site infection. Because wound infection is too broad a term. Surgical site infection is where you actually create a surgical wound and that site becomes infected. And because, as I said earlier, classifications are important, you have a superficial, this is now further classified as a superficial incisional, deep incisional, and organ-specific surgical site infections. What do you mean? When it's only the skin, that is the dermis and the epidermis, and the subcutaneous tissue involved, it is a superficial surgical site infection. This is a terminology you're going to face again and again and again. SSI. SSI rates are the ones that are compared in the world, all around the world, for various surgeries, whether it's thyroid or Whipple's or any such breast or whatever. So superficial SSI, when it touches the deep fascia and goes to the muscle, it becomes a deep SSI. And when it invades an organ like a retroperitoneum, like a subhepatic, or etc., it becomes an organ-specific surgical site infection. So when we talk of surgical site infections or a wound infection, we all know, for example, a partial gastrectomy wound which has leaked and then caused a bit of peritonitis, and then the wound is leaking through the abdomen. You got a wound infection. That is not the same as somebody who's got a small hematoma under the skin which has got secondarily infected. That is a different surgical site infection. Therefore, we need this classification: superficial, deep, and organ specific. Talking of superficial surgical site infection, contrary to what a lot of us assume, irrespective of when the patient gets discharged, anything that occurs within 30 days after the operation in the subcutaneous space will be classified as a superficial SSI. So those of us who are honest enough to include in the data, we have to include everything that occurs within 30 days. The patient comes back after 2 weeks to remove subcuticular. You have to remove the wound to let out a drop of pus. That is necessary. What are the criteria? Any one of the following. If you have a purulent drainage, or if you grow an organism from a culture of what you thought was only a serous or a serosanguinous discharge without pus, it is still an SSI. How do you recognize it? A wound which is healing about 5-6 days, 7, you expect the pain to start coming down. He suddenly has a bit more pain. When you touch it, it's a bit more tender than what you would expect at that time in the postoperative period. There's also localized swelling when the swelling should start going down. And all the classical features of inflammation we know, the calor, rubor, dolor, etc., redness or heat. And this, contrary to whatever be your CT, MRIs, all the fancy gadgets that you have, this is a clinical diagnosis. An SSI can progress but not as rapidly if you do not recognize a deep one. When a deep one can progress towards a necrotizing fasciitis, and as you all know, even today, a necrotizing fasciitis has got a mortality of over 50%. Unrecognized necrotizing fasciitis is a mortality of over 50%. It can rapidly become a systemic disease. Now, as far as wounds are concerned, one final word. For those of you who recognize this, good. For those of you who don't, almost half a century ago, there was a landmark paper. I think it was 1954. Cruz et al. And they classified wounds into these four categories. Why is this important? It's important because A, they looked at 10,000 plus post-operative wounds, not one, not two, not 100, not 1,000, 10,000 wounds. You can't argue with numbers like that. They classified all the wounds into four categories, four broad categories. These are four important categories: clean, clean, contaminated, and dirty. What do we mean? Now, don't look at the right side. Let's look at this side. I'm very fond of teaching my PGs in every single classification, and you all have hundreds of classification, grading, and staging by the time you go for your exams. The easiest way to do it is look at the first and the last, and then the second and third will almost always fall into place. If you remember, for example, if you remember stage 1 breast cancer, stage 4 breast cancer, 2 and 3 is very easy. All you have to remember is two criteria for 2 and 3. So let's look at clean. A clean wound is where there is no infection. It is the prototype of a clean wound is what a surgeon makes in the operating theater after the wound has been scrubbed and cleaned and painted and dripped. You, with a clean incision, clean scrub, you make a clean skin incision. That is called a clean wound. Classically, for example, a thyroid or a hand operation or a radius fracture or any musculoskeletal operation. Now let us look at it. I'm jumping from clean to dirty here. Dirty is anywhere where there is already an established infection. A patient comes with abscess, a pancreatic abscess, retrohepatic abscess, or an appendicitis with a perforated bowel or colonic perforation. He's got peritonitis. There is no question about it. This is a, you open, close, wash, you can use all the saline in the hospital and wash and close it. It is still a dirty wound because it is already contaminated. All right. So there is a dirty wound where, for example, somebody comes with an abscess, carbuncle on the back. It's a dirty wound. There's already a pus. So clean and dirty out of the way. What is clean contaminated? That's a very paradoxical kind of term, isn't it? Is it clean or contaminated? Now it's a clean wound, but a potential to be contaminated. There are minor breaks in sterile technique. For example, you do an appendicectomy, you're a beautiful surgeon, you're a very delicate, elegant surgeon, you do a nice appendicectomy, you are not opening the respiratory tract, the genitourinary tract, or the gastrointestinal tract. In our body, these are the three tracts that are potentially contaminated. The intracranial or the intrathoracic is not, but the respiratory tract, the gastrointestinal tract, and the genitourinary tract has got potential contamination. I'm not saying contamination, potential contamination. So if you open that tract, but you do not spill at all, so if there is only a minor break, it is called a clean contaminated. If you open it, if there is inevitable spillage, it is a contaminated wound. So somebody is, say, a duodenal perforation, you picked up early, you've gone in there is no gross spillage. But there is spillage, there is no pus as such. So that is a contaminated wound. Why is this important? Why are we looking at these categories? When Cruz looked at it, they discovered that the wound infection rate dramatically varied from as high as 40% in a dirty wound, in a clean wound, irrespective of what medical treatment was given. It was around 2%. The 5% is an outlier. It is around 2 to 3%. And the rest of them varied between 8 to 10% and 15 to 20% and so on. What it implies is in a clean wound, you cannot have wound infection rate or an SSI rate more than 2 to 3% today. In fact, whether you give antibiotics or not, it should not exceed that. All right, this is the important thing. So when you talk of wounds, when you talk of classification of wounds, you must remember to classify. Now there are a few more classifications, a few more refinements, but let's not go into that at the moment. So once you have covered that, we have what is called abnormal overhealing wounds. We talked of wounds that do not heal, wounds which have factors which impede the healing. What about wounds which have abnormal healing, overhealing, wrong, so-called wrong healing? So that is when you have, for example, hypertrophic scars and keloid formation. These two, for example, are often interchanged. There's a lot of misconceptions about it, and we will cover that at a future date. Let's just go on to a simple. Before we talk about scars and all at a future date, I want you to just remember this: the basic difference between a hypertrophic scar and a keloid. When a patient comes to you and shows a scar at about 3 months or 6 months, and of course, we don't call any wound as a scar. For a wound to become a scar, it has to be several months down the line, correct? So a scar can be a beautiful hairline scar, it can be a hypertrophic scar, or it can be a keloid scar. What is the difference? Typically, a patient comes and shows you at about 4 months a scar which is thick and raised. For example, a sternal scar or abdominal scar. It is a bit red, it's a bit raised. You don't know. At this point, you do not know whether it is going to be a hypertrophic scar only or will it progress towards a keloid scar. So the honest answer at that point is you don't know. But if it is a hypertrophic scar, it will regress. It will become worse from 4 weeks to 4 months. It becomes worse. After 4 months, it starts regressing. If it is a keloid scar, it does not regress at all. It goes through periodic phases of increase in size, increase in area. In a hypertrophic scar, although it may be raised, in general, it follows a pattern. The collagen is basically oriented. There is an exuberance, there is a proliferation, but nevertheless, there is an oriented collagen. However, in a keloid, there is no orientation. It could be very, very random. It could be all over the place, which is why you find a keloid scar spreading like a crab all over the place, small areas, small pseudo growths into it. So it's a random collagen. And in general, hypertrophic scar, however thick it is, however raised it is almost always confined to the wound. It doesn't go very much beyond the wound. A keloid scar does not act like that. It is the definition of keloid scar is that it is not confined to the wound. This is the most important definition. It is not confined to the wound, and it will continue to increase both on the vertical as well as in the horizontal dimension. And because it is a much softer one, because it is confined to the wound, you all heard of mucinous carcinomas and so on in stomach and so on, right? Now, we do not know the significance of the mucinous stroma in keloid yet. There are a lot of theories. But apparently, the keloid has far more mucinous stroma when you look at it under the microscope than a hypertrophic scar. Similarly, it does not have too many myofibroblasts. It has a lot of fibroblasts, but it does not have too much of myofibroblasts. In keloid scar, both these factors are in abundance. They might have a lot to do with the way keloids behave. They might also have a lot to do with the way our treatment is directed. I'd like to cover some of it before we go on tomorrow or day after, whatever. Okay. So going straight from the thing, we talk of the principles of skin cover. In this mainly I'm going to talk of grafts and flaps. Wounds, as we know, have always been there. There's nothing new about wounds. Ever since animals were running around, there were always wounds, and people were getting wounds, falling down, hurt, hunting, etc., etc. But it was around, and of course in wars, the huge amount of injuries in wars. So which you'll find that every time a major war, like the World War I and II, is when wounds and the complexity of wounds and also the complexity of wound treatments dramatically and exponentially progressed. And sometime around the mid 18th century to now, when society started getting slowly more industrialized, mutilating injuries started becoming more common. As transport started getting more sophisticated, more mechanized, more faster, the velocity of transport also increased. Mutilating injuries also became more common. So you started seeing injuries which are the result of both the industrialization as well as extensive transport and of course war, and therefore the need for covering a lot of these wounds. It is no more simple wound covering. And at the same time, also surgical treatment for cancers started becoming more and more radical. So people started doing more and more radical surgery, almost like the Halsted kind of a surgery. So that inevitably left large defects, and we could not leave large defects. We could not cover them. These patients used to die. Therefore, unless you're able to provide a skin cover, the cancer treatments weren't going. So along with the treatments, people needed to find a way to cover large defects, create. So something, I'm deliberately putting obviously very dramatic ones. So something like this obviously wouldn't have been even thought possible unless of course we are able to cover it with a beautiful flap. Okay. But it is an experience in the two world wars, and where people started experiencing a huge number of mutilating injuries, that we started seeing the horrendous nature of the wounds. But the difference between, so what? Wars have been there from the beginning, very early on. What is the difference? A lot of times people used to die. The mortality and morbidity was very high, even small wounds. But by the time we come to the Second World War, we could do, for example, amputations on the field. We could start treating them with antibiotics. Lysol had been discovered. Germs had been discovered. Infection was known. We were slowly getting on top of sepsis, which means a lot of these people were not dying. When they were not dying, they were having chronic wounds. So we're converting a lot of acute cases into chronic cases, and therefore there's an exponential need for providing skin cover. And what happened was, at the same, people were, it is not as if they're not doing, they were using locally available tissue, moving things around to reconstruct large defects. But along with this, we started understanding our muscular anatomy better. But more importantly, we started understanding the blood supply and physiology of skin better. As we understood the blood supply of skin, the whole thing became more and more refined. And along with this contributed microsurgery, where we knew we could take large amounts of tissue and move it around. But then I'm going ahead of myself. So let us just go back a little bit. So when we look at skin cover, to put it in a nutshell, when you look at a wound like this, we have several options. We can just leave it, which is what people used to leave, what is called secondary intent. Of course, I'm not talking about primary closure. Primary closure is really not a wound at all. You open and close. That's okay. So you can leave a wound to heal. If it is a small wound, it will heal. If it is a large wound, it might still heal with a bad scar. Or if it is a very large wound, they will die of sepsis. Or you can hasten the process by covering it with what is called a graft, a skin graft. Now, the skin graft could be a STSG, what is called a split skin graft, or a full thickness skin graft. We'll go into each of these in detail. Or you can do what is called a flap. Now, basically, when you're asked a fundamental difference between a graft and a flap, a graft is something that is removed and then put on. In other words, when you take a skin graft, it does not have any attachment to the body until you put it back, and it has to come to life. A flap, on the other hand, any flap for that matter, except free flaps, which is a misnomer, a flap basically is still attached to the body when you move it in various ways that you want. So that flap could be a local flap, or it could be a regional flap. So in other words, that flap could be adjacent to the wound that you have, It need not necessarily be adjacent that the wound that you have. We come to each of this in detail, but it's still a flap because it has got attachment to its neighbor or some tissue. Now, I'm sorry to confuse you a little bit. You all heard of this term free flap. Actually speaking, although we call a free flap, strictly speaking, in terminology wise, a free flap is actually a graft. We are taking it from somewhere and putting it in a new place. The reason why it has got away with this term flap is this pedicle. We are detaching its blood supply, but we're immediately giving it new blood supply. Therefore, it pretends like it's a flap. That is, in other words, it's still got attachment. It no more has its attachment from distally, but what we have done, we have removed its attachment and then brought the attachment somewhere else close by. Therefore, it falls under the dubious. Technically, although it's a graft, it is called a free flap. So there is something called specialized flap. We'll come to all that. That is not important, but these are the major categories. Okay. So let's look at a simple wound like this. Somebody has been run over. He has had treatment elsewhere with dressings. And this is what I meant earlier when I talked about wound healing. You see several stages happening here. You see a pink epithelium here. This wound is epithelializing. This wound is granulating. The one look at it, you know there has been dressing of sophronital gauze. You can see the square pattern here, cobblestone pattern. You know this wound is having multiple phases at the same time. And you also know that there is nothing exposed. And therefore, you know, basically a wound like this, instinctively, you know, can support a thin piece of tissue because it has already had what is called granulation and already had a lot of blood supply coming to the wound. It doesn't have any dirt. It doesn't have any devitalized tissue. It doesn't have any desiccated tissue. It doesn't have any exposed bone, cartilage, or any other vital structure or implant. Every one of the words that I said now is important. I'll be emphasizing it later on. And therefore, you know a wound like that is a simple granulating wound which can take a simple skin graft, which is a split skin graft. Okay. So what is a skin graft? Once again, it's nice to know about the history whenever we talk about it. As surgeons, you know, you might have this class today and go away. 10 years later, you might be teaching your students. 20 years later, your students might be teaching your students. But it's important to remember that what we are doing today is standing on the shoulders of giants who've been there earlier. And it's important that we remember them for two reasons. One is homage to them, so we know how much they contributed. Secondly, a lot of times in history, when you look at it, you know mistakes that people have made, so you don't go and make the same mistakes. As Santana said, those who do not read history are condemned to repeat it. So when you don't look at blind ends, a lot of blind ends in medicine and surgery. And if you do not look at those blind ends, you're going to go back into the blind end again. So history, it was as early as somewhere around the second half of the 19th century that Riverdon, a Frenchman, started taking small skin graft and put it on. And one confession here, none of these guys are plastic surgeons. The whole concept of plastic surgery did not even exist except perhaps in India at that time. None of them are plastic surgeons. Today, plastic surgery, the entire field is contributed either by ophthalmic surgeons or ENT surgeons and so on. So these are either ENT surgeons or more importantly, like Wolf here, has been ophthalmologists. So what he called epidermal grafts, small shavings. And then to his surprise, he found the shavings took. And that led the way slowly to what we now know as a split skin graft, in other words, known as a Thiersch graft. Today, the common term for a split skin graft is a Thiersch graft. The common term for a full thickness graft is a Wolf graft. Wolf with an E, not stopping the F. Wolf was an German ophthalmic surgeon. Now, what are the differences? What do we mean by a split skin graft? What is a full thickness graft? Let's go into it a little bit detail. So classically, you've all heard of your bosses say, hey, go and put an SSG on it, go and put a FTSG on it. And there's also one other category called composite grafts. What is a composite graft? Anything more than one type of tissue is a composite tissue. A skin and fat and bone, muscle and fascia, muscle and bone, skin, muscle and bone, etc., etc. They're all composite. Anything more than one type of tissue is a composite tissue, and therefore any graft more than one type is a composite graft. Okay. So coming to SSG. Now, what is the key difference between a split skin graft and a full thickness graft? A split skin graft, after you take it, has left some amount of dermis behind. That is all there is to it. You've taken the entire epidermis, you've taken some amount of dermis. Now I'm being vague here, am I not? When you say some amount of dermis, surgeons don't want to be vague at all. You want to be very clear. When you say some amount of dermis, what do we mean? This is what we mean, the thickness. So when we take a very, very, very small amount of dermis in the graft, in other words, it's almost epidermal graft like this guy took, Revedon took, maybe with a very, very thin piece of dermis. It is called a very thin split skin graft. When we take a thickish graft, we have left some amount of dermis behind, but it's very, very small amount of dermis left behind. A large amount of dermis has come with us in our graft. We call it a thick split skin graft. So there is an SSG, which is a thin SSG, where is a thick SSG. Remember, so that is the thickness. So how do we take it? Now we all think we need fancy. There is a saying in Tamil. A lot of I know that a lot of you are not Tamilians. There is something called "Vallavanuku Pullamayudam." For a brave man, even a piece of grass can be a weapon. For a surgeon, he's never deterred by a lack of equipment. Some of my best grafts are taken with a straight artery forceps and a shaving blade. In those days, we used to have what is called a 7 o'clock shaving blade. Even today, I use a 7 o'clock shaving blade, sterilized and kept in theater. You get a very, very beautiful split skin graft. But in general, people use what is called a Watson knife. This knife has undergone lots of modification from the time it is first described. The one that you see here is what is called a Watson modification of a Humvee knife. But remember, there are lots of modification. Basically, if you remember that this is a Watson knife or a Humvee knife, you're fine. So it's called a dermatome. Dermatome is nothing but an instrument to take a graft with. This is a manual dermatome where you load a blade and you take it manually. There are electric dermatomes, there are pneumatic dermatomes, and there are manual dermatomes. You can take large amount of skin using mechanized gadgets like the manual dermatome, like the Zimmer electric dermatome or the pneumatic dermatome. We won't go into that in detail. The next factor is donor site. Where do we take skin graft from? This is the beauty. As far as the split skin graft is concerned, you can take it from virtually any part of the body. I make this again, I'm repeating. You can take it from virtually any part of the body, from the scalp to the sole of the foot. You can take it from anywhere, and I have. But that doesn't mean you go and take it from the scalp or the sole of the foot every time. You can. When I say you can, that doesn't mean you may. In certain circumstances, you can. But what it means is, even if you take it from a part, that part will heal. The donor site will heal because you left behind elements of skin behind, and therefore the donor site will heal. But commonly, we take it from from places where, number one, the skin is very thick and very easily available, and technically it's very easy to take a graft from. Classically, all you have seen the thigh, the lateral aspect of the thigh, the upper aspect of the thigh reaching on to the buttock. Why? Because it is very easy to hold, to create a convex surface, manipulate the thickness of the skin that you have, and take the skin graft. We'll come to all that later. The next factor to consider is how do you prepare a wound? Do you take a patient comes, do you take a graft and put it on? No, you can't. Like when you take a paddy field, those of you who notice this, the farmer does not transplant a paddy from somewhere and simply go and put it. He prepares the field first. Even a paddy, you have to prepare the field for it to be able to take. Our wound is like a paddy field. The graft that you're taking is like the transplanted paddy. You're going to take it from one place and put it so that it can come to life. So you have to prepare the wound bed. By preparing the wound bed, what does it mean? It means number one, you cannot afford to have an infection. Number two, it has to be ideal. It has to have a good vascular bed. It cannot afford to have an exposed bone bare of periosteum. It cannot afford to have a metal or a plastic or a silicone or any other foreign body jutting out. So in other words, it has to have a surface which will support and nourish a skin graft. And that wound has to be prepared. Okay, so you prepared the wound, you isolated the donor site, you got the dermatome, you decided what thickness. Once you're taking the graft, then the next factor that you have to consider is how am I going to keep it in place? The most important point in any musculoskeletal healing is rest. If you do not rest a part, it does not heal. So it is with a skin graft. If you do not rest it, it will not heal. You cannot put a skin graft and mobilize it and expect it to heal. It will not heal, which means you need to fix it. Not only do you have to fix it, but you have to immobilize it. To immobilize it, of course, you have to fix it. Otherwise, you cannot immobilize it. So you need to know how you're going to do it. And there are various ways of doing it. And once you've decided on a method, whether you're going to put a thiol dressing or you're going to put a vacuum assisted dressing or whatever, and then you need to know what kind of a dressing on top of it that you're going to put. Now, the interesting word that I put is storage. Now, we are not talking about storage of a patient. All plastic surgeons, when they take skin grafts, they take a little bit more than what is needed. Because sometimes you lose grafts. Sometimes you may not be able to put a wound. You think a wound is ready, it's not quite ready, but it will be ready in 2-3 days' time. But you're not going to give the patient another anesthesia, another surgery, just so that you can take a skin graft. You take a skin graft at the time that you've done the debridement, that you've done the cleaning, that the patient is under anesthesia. If you think the wound is going to be ready very soon, or if you think you're going to need extra grafts. And then you need to know how to store the graft. There is ways and means of properly storing a graft. But storage is important. We will not get digress into that at the moment. The other aspect is the most important thing that has happened in the last, say, 30 years or so is what is called a mesh graft. Prior to 1970 or 80, people used to take a skin graft, put it on there. And then somebody started noticing that a lot of grafts are large because there is hematoma. Some of the grafts were lost because there is seroma, lifting of the graft, and the entire graft was lost. And somebody had the bright idea, you make small holes in the graft, you allow the blood and seroma to come out, at least the remaining part of the graft will get stuck to the wound. This concept got further and further refined. People started doing what is called meshing. So you do an organized meshing of the wound. It has got two advantages. In fact, it's got three advantages. Number one, it allows any collection underneath, be it a hematoma or a seroma or any other fluid to come out. But importantly, because you mesh, it allows you to expand the graft. And it can be expanded to 1.5 times, twice, thrice, up to 6 times. Because it is now a lattice network, it can be expanded. What is the advantage here? When somebody's got a wound which is much larger than the available donor site, you're going to have to make do with a small amount of graft to cover a large defect. Therefore, you need to expand it. You cannot expand a sheet of skin. However, you can expand a lattice framework. And we know from experience that the interstices between them heal. The smaller the interstices, the faster they heal, but nevertheless they heal. So that is an example of a measure. That is a manual measure. It You have several types of measures available. You can see this is how the skin graft goes. What you see here is a small little transparent thing, is a plastic sheet. As the wound moves, it gets meshed, and you can see that I'm expanding this. The whole thing can be expanded. and the interstices heal very well. Okay, so you can expand it, you allow all the fluid to come out. What is the third advantage? Because any mesh, like a lace, is a bit more pliable than a sheet, and therefore wounds don't come with a nice beautiful 4 into 4 flat surface. They often come with uneven surfaces, one corner tucked in, one convexity, one concavity, one deep corner, one crevice here, one crevice there, etc. A mesh graft goes into the crevices much better than a sheet graft does, at the same time allowing the fluid to ingress. So it expands, it can contour well, it allows the fluid, whatever fluid that might be, to come out. Here, look at this. This kind of wound is going to exude whether you lay it or not, and it's got up, it's got down, it's got a crevice. So a mesh graft, you can see this is a mesh, and it can nicely go up and down, and contour on the surface extremely well. What is the disadvantage? Obviously, the more you mesh, the larger the interstitial area. And remember, every interstitial area is going to heal with how? It's going to heal by secondary intention. It will heal because it's a small area, it will heal. But every one of those areas of secondary intention will contract. We know that the wound will contract. A wound which heals the secondary intention contracts more than a wound which is primarily closed. A wound which heals with a graft will contract less than a wound which has got secondary intention. Therefore, all these small meshed areas that will contract. And of course, as because the contracted area or the area which is healed with secondary intention heals at a different rate, at a different type and a different color and different texture and different quality to the healing, the cosmesis will also be different. So somebody who got a mesh skin graft put on the dorsum of the hand will look like he's got crocodile skin on his hand. You might not have had a choice. This patient may not have had a choice. He might have had no donor site. So it is a question of saving his life versus cosmesis. But nevertheless, it cosmetically it is going to be bad. So you have to remember that. So while the advantages is good expansion, contouring, allowing fluid, the disadvantages because it contracts and it also gives poor cosmesis. Now we talked of donor side. We need, we, uh, in plastic surgery is all about robbing Peter to pay Paul. So we got to look after Peter as well as Paul because that is something the patient did not have when he comes in. So I am using an area which was normal. Therefore, we have to look after that area to make sure I don't create more injury. It will be a tragedy if the patient's original wound healed up and the wound that I created goes on to have an infection and bad cosmesis. So a donor side is going to continue to ooze because it is a partial thickness. It is going to continue to ooze, put out blood and seroma. So you need to have an absorbent dressing which will absorb all of it. Therefore, you need to have an adequate padding. And for that also to heal, you need to have a good immobilization. And this is very important because you every time you lift a epithelializing wound, you lift off the superficial layer of the epithelium off. Therefore, there's no frequent dressing change, which is why, in general, there are a lot of exceptions to this. In general, you'll see that most of the time when you do a plastic surgery posting, they'll say donor side dressing after 10 days to 2 weeks. Why? Because as it dries up, it will lift off. So unless there is strong reason to suspect there is an infection or there is something else happening, you do not normally disturb the donor side. So do these fail? Yes. We talked of preparation. So if you don't have a good graft bed, if you have a very poor vascular heal bed, somebody's had radiotherapy, somebody's had repeated surgery and scarring, there's no bleeding at all, it looks like this, so it's going to have inadequate graft bed, it will not support. Somebody's had a debridement, the pressure is low, so you think you've got a good hemostasis, patient wakes up, fluid is given, BP comes up, small blood vessels which had gone into closure starts bleeding, and you have a hematoma in the wound, that's going to lift off the wound, lift off the skin graft. You got a graft on the dorsum of the foot, the patient doesn't know, he goes to the toilet and back because you didn't tell him You cannot go to walk to the toilet. You didn't give very specific instructions about it. You did not put a POP on the leg. The guy is moving his ankle and dislodging. Every time he moves, it dislodges a graft. Therefore, that's not going to move. And of course, I don't need to tell you infection and technical error. I can go on and on about technical errors in terms of how you put the graft, how you take the graft, and so on. But if you're putting graft secondarily, it has to be stored properly in the correct temperature, in the correct manner without drying out. If you don't, a secondarily applied skin graft will also fail. So sequelae. Now earlier I talked about complications. So there is a difference when people talk about sequelae and complications. Complications are something that you don't want. Can happen, but you don't want. Sequelae is something also you may not want, but it's always going to happen. Correct? So when you go to a hospital and then you have operation, you're going to have a scar. There is no question of not having a scar. That's a sequelae. The scar can become a keloid. That's a complication. So sequelae is an inevitable one. A complication is not. In the short term, you can have problems with graft take, you can have problems with donor site, but in the long term, as the scars, as the grafts mature, you can have contraction, and the thinner the graft, by our definition, the thinner the dermis we have included in the graft, and therefore the contraction is more. The important concept here, the amount of contraction will depend on the amount of dermis. Therefore, that is why in a full thickness graft there is hardly any contraction. In a very, very thin graft, there's going to be huge amount of contraction. So the less the dermis, the more the contraction, and therefore the contracture. Contracture is a terminology we use when it involves joints. Contraction can be anywhere. Any wound which contracts is a contraction, contracted wound. But when the contracted wound or a scar involves a joint like this, it is called a joint contraction. All right? And of course, pigment changes. These are unpredictable. You can have hypopigmentation. You can have hyperpigmentation. You can have variegated motile pigmentation. That is inevitable. Then the reinnervation in a graft, it could be unpredictable, could be uneven, and it happens, but it happens over a period of time, and it could be patchy, and it will never going to be complete, because the reinnervation is not the same as the nerves growing back and finding their end organ. Number one, there are no end organs. At best, what one hopes is to have a proprioception, a pain and vibration sense, and perhaps some kind of a touch, perhaps. And of course, as I mentioned before, cosmesis is a problem on how you do it, what kind of grafts you put on, and so on. Now, one of the inevitable sequelae of a grafted wound is going to be dryness, because by definition, a graft is a skin graft is a partial thickness that has come out. It does not have the sweat glands and oily glands, which are actually in the subcutaneous region, which go below the reticular dermis. And because they go below the reticular dermis, and a split skin graft does not go beyond the reticular dermis, you are cutting them off, so you do not have the adnexus of the skin. Therefore, a skin graft by definition and by function and by design is dry. And therefore, you often find this complaint. They'll say it's very itchy. And you must realize when somebody says it's very itchy, the commonest cause of itchiness is dryness. And it gets much worse in winter, in dry atmospheres. The need for repeated moisturizing lotions, etc., etc. And that is why you find, unless you do that, patients are going to keep scratching, secondary infections from the nails, lymphangitis and cellulitis and so on. Now you understand where in a chronic wound, with a grafted wound, people come back to you with repeated cellulitis, you must suspect that they have been scratching, and the scratching is due to dryness, and that unless you tackle the dryness, this infection will not go away.
Dr. Shivaram, I'm afraid we have to.
Right, okay, I can continue this in the second thing. Okay,
yeah, and take a few questions before.
Sure. I'm going to stop sharing the screen at the moment.
Yeah. Any questions from the audience? We have about 10 minutes for questions.
Do we have an idea how many people are there?
80. 80, they were 86, now they're about 78.
Wow. Okay.
And any questions from the audience?
Yes,
Sir,
yes,
Yeah.
sir.
Dr. Dawal?
Yeah, hi, you're on.
Dr. Amaravani?
How
sir,
many days after we have to
when do you
Carry on, Amaravani.
uh,
Carry on.
when do how do you cover the shin?
Very good question. Now, we haven't come to that at all. And one of the talks that hopefully Dr. Radhakrishnan is going to do the series is covering lower limb trauma. And I got a full lecture for you for that. And we'll cover that. But we once again, when a question like that, if you get a question like that in the exam, you don't start by saying the options available. You start by classifying. So that depends on whether you have a compound fracture, what is exposed, what is the, where is it? Is it we divided into upper third, middle third, lower third? There are definite options available for upper third. There are definite options available for middle third, and there are definite options available for lower third. The just to jump the gun because you asked this question, the middle third is inevitably the area over the shin that you asked for. Typically, the what is called a pre-tibial laceration. And if the periosteum is intact, you can still put a skin graft. But if the periosteum is not intact, you will need to do what is called a local flap. Inevitably, it's a fasciocutaneous flap. As I said, I shall come to that much later.
Thank you, thank you.
Dr. Dawal? Dr. Dawal, what's the question? Dr. Ajay Verma?
Excuse me, sir.
Yes.
Yeah, carry on.
Sir, you said that for donor site absorbent dressing is needed, but previously you again said that for healing purpose, liquid environment or humid environment should be needed. So, absorbent dressing, will it not be causing desiccation to the healing process or hampering the
Okay.
healing process?
Good question. Now, you have to balance things out. A wound which is enormously exuding is different from a wound which is moderately exuding. In a superficial wound, which is only mildly exuding, you need to keep it in an occlusive moist atmosphere. In a wound which is going to produce a huge amount of serous or whatever exudate, for example, in a superficial burn, uh, we cannot afford to have a moist dressing which will increase it. A split skin graft is just very superficial, almost like a top layer of the dermis has just come off. So the bottom layer is going to continue to ooze. And certainly the first 3-4 days is going to continue to ooze. And therefore, irrespective of the absorbent dressing that you put, it will continue to remain moist. But why I said a good question was this fact was recognized, and that is why you had what are called both an occlusive and a hydrocolloid dressings. Today, what we do is, for example, one of the important dressings is what is called, commercially it is known as caltostat, but generically it is a calcium alginate. Alginate is a seaweed. Seaweed is something that absorbs a lot of fluid, at the same time keeps it moist. In other words, it doesn't allow the wound to become very dirty and wet. It absorbs it. It's like a gel which sits on top of the wound, having absorbed the top, but the layer in touch with the wound is still a bit moist. So a dressing like that, a calcium alginate or a hydrocolloid or similar dressings, and hopefully one day I'll be talking to you on the principles and the guiding what kind of dressings to use when, in what circumstance. Hopefully we'll cover that at this point. And when I say absorbent dressing, it is initially this wound puts up a huge amount of exudate, therefore you need absorption. But towards the latter part, you're right.
Dr. Meghna?
Thanks, sir.
Good evening, sir. So I have two questions. Sir, while classification of the bone, you had mentioned about 4 types. So in the perianal areas like fistula, nano, or hemorrhoids, so where do we classify these bones into?
By definition, a perianal wound is a contaminated wound. By definition, you cannot have a clean wound in the perianal region.
Right. Sir.
You cannot. So it's simply, when I said clean wound, it's where it is not in proximity to a GI tract or a genitourinary tract or a respiratory tract. Now, a fistula, or if you've done a piles operation, it is not a, it's a contaminated area. It is not even a clean contaminated, it's a contaminated area. You're right in the tract.
Jordan? Jordan, your question?
Sir, good evening, sir.
Hi, good
So
evening.
my question is in relation to your wound healing. So a
Yeah.
person had a lacerated wound on the forehead. It was stitched around 4 weeks back.
Okay.
There is a slight beveling of the edges at the lower end. The
Okay.
patient is very conscious that he desires a scar revision. So
Okay.
how can we go for a scar revision in such patients, sir?
Okay. For a start, as I told you before, at 4 weeks it is not a scar.
Right.
So it is a wound.
Uh-huh.
So first thing, you must inform the patient that a scar is going to continue to mature over a period of 4 months to 6 months. It can
Right,
get
sir.
better, it can get worse. We don't know.
Right, sir.
Now, he has two options. One is to allow it to become better. There is very good chance that it will get better with some massaging and so on and so forth,
Right.
which we'll cover in hypertrophic scar when we come to that. Then he'll avoid surgery. Or if he's insisting, you can redo the wound. You can cut it and re-suture it. But with a very big B, you must warn him that any scar cannot, just because you have redone it, that doesn't mean it's going to form a good scar. It can still form a bad scar.
Right,
We
sir.
don't know. So my general approach is to try and convince the patient, please wait. Please wait for at least 4 to 6 months time when we know the scar is getting better or worse. There is a misconception that you have to do it very early so that you avoid. No, it doesn't really matter. You don't do it very early, unless you are in a place where there is a distortion. For example, there is a severe distortion of the eyelid. There is a distortion of a landmark, and therefore you need. For example, if eyelid is pulled, you're going to get an ectropion, etc., etc. That's a functional problem. When you rule out a functional problem for
Right.
purely cosmetic reason, one does not jump in. You have to wait.
So it's basically reassurance, sir.
Yeah, absolutely, and follow up. Don't tell him it will get better and go away. Tell him it may get better, it may not, but I want you to follow up. So take photographs. What do? We take serial photographs.
Okay, sir.
And then intervene when you think it's getting worse.
Right. Sir.
There's so many people with raised hands, but I have one last question before we go. Ramakrishna Reddy. Ramakrishna Reddy, what is the question? Yes?
Yes, Ramakrishna. Suman Tatikonda.
Sir. Hello, sir. Good evening, sir.
Your audio isn't very good, yeah?
Also, audio is not very good. Plus, in the chat, I'm seeing a huge number of chats. I'm sorry, I obviously can't do both. So
no, but,
I have to do that.
Dr. Shivaram, with your you are condescending enough, and you a lot of lectures. I think many of these questions will be covered.
Yes, will be covered.
Yeah.
Your audio is not okay. Ramakrishna, your audio is not okay.
I can't hear you. So on that note,
donor side and recipient side for pigment matching, how can we?
Yeah, this is a very difficult question. It's an extremely difficult thing. Even plastic surgeons can't answer it very well. But we'll cover that at the end of the flaps session. We haven't even covered full thickness graphs yet, so we are jumping the gun here.
So on that note, thank you so much, Shivaram, for taking such pains and
my pleasure.
Teaching so very well. Actually, I'm learning plastic surgery because I think wound healing is relevant to everyone. Thank you so much again, and we shall get back when you have time. Thank you.
Thanks. Bye.